Hello and welcome to Module 3 of your 2014 Medical Treatment Guidelines Protocol Training. This module is designed for intermediates and paramedic level providers. Training was developed by the Department of Fire, Rescue, and Emergency Management Training Division, Lieutenant Matthew Shields and Lieutenant Mary Hart. We encourage you to follow along in your protocol book during this training. We're going to talk about all 54 protocols contained within the protocol book, and we're also going to talk about what other provider levels can do for the patient. That way, if care has started prior to your arrival, you will know what has already been done. Okay, so let's start with Protocol 1, the Universal Patient Care and Initial Patient Contact Protocol. This is a simple patient assessment protocol. There's a few parameters in here for all provider levels. We want to maintain an oxygen saturation greater than 94%. We want to assess capnography and maintain an end-tidal CO2 reading of 35 to 45 millimeters of mercury. We also want to get a glucose analysis and 12-lead EKG if indicated. And of course, we want our IMP level providers to interpret that 12-lead. Also, if IV is indicated, obtain IV access. Now, this protocol is going to break your patient down between trauma and medical. For trauma, it'll break it down even further into whether or not they had a significant mechanism of injury or not. And for your medical patient, whether or not they are unresponsive or responsive. Now, the terminal end of this protocol always asks you to exit to the appropriate protocol. Protocol 2 is our behavioral and patient restraint protocol, and of course, our priority in this emergency is whether or not the scene is safe. So for your treatment, all provider levels, we need to get a good assessment on these patients, including blood glucose analysis and history gathering to determine whether or not this behavioral emergency is caused by a medical condition. Also, we need to consider physical restraint. Our advanced through paramedic level, IV access if safe to do so, and for our INP level providers. If the patient is aggressive and a threat to self or others, and we are able to restrain the patient, we need to administer midazolam 2 to 5 milligrams IV, IO, IM, IN every 3 to 5 minutes as needed. Or also we have Haldol or haloperidol, 5 milligrams IM, 2 to 5 milligrams IM if age is greater than 65 years old. Now, if the patient has excited delirium syndrome, we want to start off with Haldol. Same dose, 5 milligrams IM, or 2 to 5 milligrams IM if they're over 65 years old, and then Versed, 2 to 5 milligrams IV, IO, IM, or IN every 3 to 5 minutes as needed. Okay, so let's take a look at haloperidol or Haldol, the first of our new medications within these protocols. Haldol is an antipsychotic and a neuroleptic. Its indication is for chemical restraint. There is a black box warning on Haldol. Patients with dementia-related psychosis who are treated with antipsychotics such as Haldol are at an increased risk for death. In short-term controlled trials, death in trials appear to be either cardiovascular in nature or infection. This medication is not approved for treatment of patients with dementia-related psychosis. Okay, so as we said before, Haldol is an antipsychotic and a neuroleptic. It reduces nervous tension by depressing nerve functions. Its action is to block the dopamine receptors in the brain responsible for mood and behavior. It also has some antiemetic properties. Its indications are for schizophrenia and psychosis. Contraindications, it's not to be used in the presence of other sedatives such as Talwin overdose and pentazocine overdose. And pentazocine is an analgesic that is less addictive than morphine. Also, patients with Parkinson's disease. Side effects to Haldol are dystonic reaction, respiratory depression, seizures, insomnia, and hypotension. We also need to be on the lookout for orthostatic hypotension when we administer Haldol to our patients. The dose for Haldol, if they are less than 65 years old, is 5 milligrams IM. If they are greater than 65 years old, we're going to half that, give 2.5 milligrams IM. All right, just a few notes on Haldol. We consider Haldol for patients with a history of psychosis only, and Versed for patients presumed substance abuse. All patients who receive chemical restraint must be continuously monitored by ALS personnel. And of course, we do not position or transport any restrained patient in such a way that could impair the patient's respiratory or circulatory status. All right, protocol 3 is our cardiac arrest adult protocol, and there's something new in this protocol, continuous compression CPR, CC-CPR. This protocol starts off with a patient in sudden cardiac arrest. We're going to immediately go to 200 chest compressions, which is 2 minutes of CPR, or 100 compressions a minute. We'll insert an OPA, and we're going to apply a non-rebreather mask at 100% oxygen. Rhythm analysis and a single shock without pulse check, and then continue on with 200 chest compressions, rhythm analysis again. Now at the top right-hand corner, there's a box that says as early as possible, and we're going to discuss that in the next slides. Okay, so for our cardiac arrest adult continuous compression CPR, like I said, 200 chest compressions, 2 minutes of CPR. We insert the OPA, apply non-rebreather mask at 100% oxygen, and we analyze the rhythm. Single shock if indicated, without a pulse check. Contraindications to continuous compression CPR are children under the age of 8 years old, known suspected overdose, respiratory cause of arrest, hypothermia, near drowning, and traumatic arrest. Of course, with these contraindications, if we already know the cause of arrest, we need to immediately reverse what's going on so we can hopefully get a pulse back in our patients. If this is the case, we begin standard CPR and or go to the appropriate protocol. Okay, also under Protocol 3, you have the ability to terminate resuscitative efforts after 25 minutes if your patient has not regained a pulse or had a return of spontaneous circulation. Of course, you want to contact medical control, and in the policy section of these protocols, there is several guidelines that must be followed for discontinuing pre-hospital resuscitation. The first of which is the patient must be 18 years of age or older, or family of a minor is agreeable after consultation with medical control. Adequate CPR has been administered. Successful management of the airway with verification of device placement. Acceptable management techniques including intubation and supraglottic airway devices such as our King Airway. Arrest was not witnessed by EMS. No return of pulse at any time during resuscitation. No shock delivered during resuscitation. Minimum of 25 minutes of resuscitation must be attempted, and all EMS personnel involved in the patient's care agree that discontinuation of the resuscitation is appropriate. So if all of these criteria are not met and discontinuation of pre-hospital resuscitation is desired, we need to contact medical control. We need to be sure that we use all diagnostic tools available to us. End-tidal CO2 is the best indicator for ROSC, as well as pulse oximetry and an ECG. Also, at the top right-hand corner of Protocol 3, there is a box that says as early as possible. And for our advanced providers, as early as possible, they need to establish an airway with the blind insertion airway device. For the IMP level providers, it's either a King Airway or intubation, as well as IVIO, and also administering epinephrine 1 milligram 1 to 10,000 every 3 to 5 minutes. As early as possible means as long as it does not interfere with continuous compressions.